Good morning. It's my pleasure this morning to introduce Andrew Cheng, who everybody knows anyway. Andrew's based at the VA and directs the, he's a site director for the Cardiology Fellowship and the Cardiology Residency program at the VA. Andrew received his bachelor's degree in chemistry from Harvard and then spent 3 years in DC doing healthcare policy research before going to Emory for medical school. Andrew came here for internal medicine residency and cardiology fellowship and worked with Francis Kim and then with Peter Byers and Catherine Otto, which accounts for his interest in bicuspid valve and connective tissue disease that I'll talk about today. So it's really great to have you speak to it with us today.
Thanks a lot, Kevin, for that introduction, and thanks for coming. So today I'm going to talk about the aortopathies associated with the bicuspid aortic valve. And what I like to do is start out with a little history and take you back to the Renaissance in the 14 and 1500s with Leonardo da Vinci. Now, when Leonardo wasn't working on his masterpieces such as the Last Supper and the Mona Lisa, he would spend his spare time going to the hospitals and he would actually dissect human corpse. And it seems like he was fascinated with human anatomy, and he had made several detailed drawings of the heart as well as other structures, and you can see some of his drawings here. So Leonardo has been given credit for being the first to describe the bicuspid aortic valve. And as you can see here, he drew this bicuspid aortic valve as well as this quadricuspid valve. Now, most historians don't believe he actually found a body that had a bicuspid aortic valve, but he imagined that it could exist. And he also theorized why the tricuspid aortic valve is actually superior to the bicuspid and quadricuspid aortic valve due to its hemodynamic properties. And so it seems like, we're just now beginning to really understand what Leonardo already kind of appreciated over 500 years ago. So there was this long lull after Da Vinci's first description of the bicuspid aortic valve. There wasn't much talk about BAV until about 300 years later, when in 1844, Paget described it as a peculiar liability to disease and a pathologic curiosity. And then in 1858, a London Dr. Peacock noted that the bicuspid valve becomes thick and ossified and induces obstruction and incompetency. And then in 1886, Osler linked bicuspid aortic valve with endocarditis. So it wasn't until 1927 that the association between BAV and aortic dissection was made, and was made by Maud Abbott, one of the pioneers in congenital heart disease. And she was actually doing an autopsy study on coarctations. And what she noted, and she writes, "It seems probable that the thinning, which is not infrequently seen in the wall of the ascending aorta in these cases, may also be of congenital origin and due to the same arrest of development that leads to an incomplete evolution of the endocardial cushions destined to become the aortic cusps." So it seems even during this early kind of discovery of BAV, she already began to surmise there must be a genetic link between the aorta and the aortic valve. So today's talk, I'm going to begin by giving some statistics on the bicuspid aortic valve and aortopathy. I'll then talk about BAV morphology and if morphology can predict pathology. I'll go over some of the prevailing etiologies of aortopathy, namely the genetic and hemodynamic hypothesis. And then finally, I'll review some of the evolving guidelines associated with treatment of BAV aortopathies. So as many of you are fully aware in this audience, bicuspid aortic valve is the most common congenital abnormality. And there's been a number of studies looking at BAV incidence. The most often quoted is that by Larson and Edwards. And it was published in 1984, and it was a necropsy study. They had over 21,000 necropsies, and they found that about 1.4% had a bicuspid aortic valve. One reassuring statistic is that in general, people with BAV do generally well. And if you look at the survival curve at the time of diagnosis and then 25 years post-diagnosis, they do just about as well as the observed population. One thing I think we should point out is that these people are being diagnosed pretty early on, so they're in their 20s and 30s. So 25 years post-diagnosis puts them at their 50s or 60s, so it's not surprising that they're doing pretty well. If you actually look at the surgical referral cohort, and these individuals are symptomatic, it's also not surprising that they do worse than the general population. We also know that bicuspid aortic valve is associated with a significant amount of morbidity. So over 50%, as you can see from this curve, require an aortic valve replacement within 25 years of diagnosis. And most often, they will require AVR for symptomatic AS, but there's a smaller but not trivial number that actually require an AVR for isolated aortic regurgitation, up to 7% in some studies. The association with endocarditis and BAV has been reported anywhere from about 0.3% to over 2% depending on the study. And the second most common complication associated with BAV is aortic surgery. So as you can see from this curve, over 25% of individuals will require aortic surgery within 25 years of diagnosis. The most common cause is aortic aneurysm. A rare but coarctations also happen, about 3%. And then, of course, the most fatal consequence, aortic dissections, also occur. So what do we know about aortic aneurysms and bicuspid aortic valve disease? One of the earliest studies was done by Rebecca Hahn and Richard Devereaux, and it was published in 1992 in JACC. And what I want to highlight is that even if an individual has a normal functioning valve, at least by Doppler, their aorta still tends to be larger than those with a tricuspid valve. And what they also found in this study was that if there was a valve lesion, such as significant aortic regurgitation or aortic stenosis, then that dilation becomes more prominent. So the prevalence of aortic aneurysm with bicuspid aortic valve has been reported as being anywhere from 20% to over 80%. And I think this variation has a lot to do with the age of the population being studied, as well as the definition of aortic aneurysm. If you define aortic aneurysm as being, or aortic enlargement as being over 2 standard deviations above the norm, then over 50% of those individuals, less than 30, will be diagnosed with aortic enlargement. And by the time an individual with BAV is 50 or 60, they have a 90% chance of having aortic enlargement. Up to 10% have aortic aneurysms over 5 centimeters. And what we also know is that the rate of growth of the ascending aorta in those with BAV is considerably higher than that of a tricuspid aortic valve individual. But we also know, as shown in this study in Heart, published in 2014, is that not everyone has progressive aortic dilation. So they looked at these individuals with BAV and followed them anywhere from 3 to 5 years, and 43% of individuals had stable aortic dimensions. And this is in contrast to those with Marfan syndrome, where you can see over or about 80% will have continual aortic growth on a yearly basis. So the real question is not aortic aneurysm, But the real concern, of course, is aortic dissection. And so I don't know if many people recognize this, but probably not the millennials, but this guy's name is John Ritter, and he was a famous actor in a sitcom called Three's Company in the 70s. And he had an undiagnosed bicuspid aortic valve and ended up dying unexpectedly from an aortic dissection. And interestingly, his brother was subsequently found to have a bicuspid aortic valve with a large aneurysm requiring repair. So what is the kind of prevalence of aortic dissection in BAV? And that's been a really difficult number to get at. If you look at the IRAD database, it suggests that a bicuspid aortic valve is present in approximately 9% of those who dissect at an age less than 40. The most common diagnosis in that cohort of populations is Marfan syndrome. If you look at some large necropsy studies, BAV has been noted to be present in anywhere from 7 to 15% of those that suffer from a fatal aortic dissection. Now, this doesn't get at the prevalence rate since we don't really know what the denominator is. So one of the early landmark studies that tried to look at this was this study by Larson and Edwards, this necropsy study. And they noted that out of their over 21,000 individuals, 161 had dissections, some ascending, some descending. And then they looked at just specifically the BAV group, and there was 18 dissections out of 293 individuals. So this gives us a rate of about 6%. And this is nine times higher than you would expect in the tricuspid aortic valve population. The other point I like to make about this study is most of these necropsies were taken in the 1960s, the 1980s. This was done in Mayo. It was a single center study. And these patients probably weren't carefully followed or surveyed, so perhaps this represents more of a natural history study. More contemporary studies have shown that the dissection rate for BAV is actually quite low. And so this was a study published in JAMA in 2011 looking at the Olmsted County population, Mayo Clinic, and basically they followed 416 individuals with a bicuspid aortic valve, and over a 25-year period, there was only 2 acute dissections. This still gives us a dissection rate that is about 8 times higher than you would expect in the general population, but the absolute incidence is very small, 3.1 per 10,000 patient years. The other point I like to make about this study is that most of these individuals were diagnosed at a very young age. I think the mean age of this study was about 30, and their aortic dimensions at the time of diagnosis was normal, 3.4 centimeters. The other point is that this patient population was carefully followed and surveyed, and as soon as they met the guideline parameters, they would get aortic repair. So this is really a kind of on-treatment dissection rate. Nevertheless, it's still quite low. How about the coarctation effect? So we know that about 50% of those, or maybe even more with coarcs, have a bicuspid aortic valve. And this study published in 2009 looked at the aortic complications associated with BAV alone, which you see in red, and those with a bicuspid aortic valve with coarcs. And it's not surprising, but we see that the cohort with a coarctation have higher rates of aneurysm, and they also have higher rates of dissection and rupture. I think this was an interesting study that was published from OHSU just, I think, this year. And what they decided to look at was aneurysms based on control and compared it to those with a normal valve, a tricuspid valve, with a coarct versus those with BAV and a coarct. And what they found was individuals with just a coarct alone tended to have aortic sizes that were very similar to the control population, but individuals with a BAV plus a coarct had larger aortas, suggesting that perhaps it's the BAV that actually confers the additional risk for aneurysm. So I spent a little time talking about aortic aneurysms and the association with BAV, and we also know that individuals with BAV have a higher risk of dissection. And even though it's a fairly rare event, it's probably something we just can't simply ignore because it's often a fatal event. So there's been a lot of investigators that have been interested in trying to figure out or better predict the risk of a particular individual. And one simple way that could work is if we could look at morphology and predict risk. So the question arises, can BAV morphology actually predict clinical phenotype? I think one of the challenges in looking at this is that there's been a number of classification systems associated with BAV morphology, and I don't think at this time we really know what's the right classification system, and are we even using the right categories to classify an individual. So the most common, or probably the most widely cited classification system is the one published by Sievers and Smittyk in 2007. And what they looked at, or they based their classification systems basically based on the raphe, or the ridge that forms between the two leaflets that are fused. And they described a type 0 BAV as being one without a raphe, so some would call that the unadulterated or pure bicuspid aortic valve with two equal sized leaflets. A type 1 BAV is an individual that only has one raphe, and a type 2 bicuspid aortic valve has two raphes. Dr. Otto and Ben Schaefer here at the University of Washington developed a different classification system in 2000, and I think this was in 2009 or 8 in heart. And what they based their classification system was on cusp fusion. So if you have fusion of the right and left coronary cusp, regardless of the presence or absence of a raphe, that's known as a type 1 BAV. A type 2 BAV is the fusion of the right and non-coronary cusp, and this rare type, which we don't see very often, is fusion of the left and non-coronary cusp. The most common bicuspid aortic valve is this type 1 with a single raphe. Some might argue that, we really, why are we looking at raphes or even cusp type, but what we really should be looking at is the number of commissures and where those commissures are located. So if you have 3 commissures, then when you open up the surgical specimen, the surgeons probably can see this much better than we can, but they see that there's 3 cusps, and this is a true tricuspid valve. Whereas if you only have 2 commissures, as you can see in this specimen, it's a bicuspid valve, and here you have a raphe. If it's a commissure, so there's no commissure, or there's only 1 commissure, then perhaps it shouldn't even be described as a bicuspid aortic valve, but it's a unicuspid valve. And we may be actually misclassifying a fair amount of individuals that have a unicuspid valve, and perhaps this actually confers a completely different etiology and pathology. So I think that's a bit of the challenge of trying to figure out and classifying the morphology of BAV. There's also been a number of descriptions for BAV aortopathy. And there's basically been 3 types that have been described. So there's type 1, which is dilation of the ascending aorta with preservation of the aortic root and the aortic arch. And this is the most common type that we see with bicuspid aortic valves. There's also type 2, where we see, it's also known as the arch phenotype, and it's dilation of the ascending aorta and the arch with preservation of the root. And finally, there's the type 3 phenotype, also known as the root phenotype, where there's dilation of the root, the sinus of Valsalva to the sinotubular junction, but preservation of the ascending aorta and the arch. So it's interesting that in bicuspid aortic valve, this is the least common phenotype that we see, but it's the most common phenotype that we see in connective tissue disorders such as Marfan syndrome. So can BAV morphology predict aortic stenosis? And there's been a number of studies looking at this, and there's been a lot of mixed results. So a population-based study by Michelina at Mayo Clinic found that there was no relationship between BAV valve type and degree of AS. In a smaller study looking at about 75 patients, this was a little bit of an older study, they found that actually fusion of the right and left coronary cusp was more likely to develop rapid and aggressive aortic stenosis, where a more recent study published in Heart by Evangelista, it's probably one of the bigger studies, actually found that fusion of the right and non-coronary cusps seemed to correlate with higher risk of AS. There's been a lot of mixed results, and at this point, I think it's really difficult to confidently predict at least aortic stenosis from valve type. And in reality, if these patients live long enough, they're almost 100% will develop aortic stenosis within their lifetime. So how about BAV morphology and aortic regurgitation? There's been a lot of thought that those individuals who have a root phenotype will more likely have aortic regurgitation, and that kind of makes sense to me. But again, the studies have been a little bit mixed, and they found that actually aortic regurgitation is independently associated with those with a root phenotype as well as those with an ascending phenotype. We know that men are more likely than women who have BAV. They're more likely to have aortic regurgitation. We also know that aortic regurgitation occurs at a much younger age than those that develop significant AS. But at this point, as in aortic stenosis, I don't think there is a clear association between a valve type and AI. So what about BAV morphology and aortopathies? I think the data has been a little bit more consistent in looking at this. And this was a study published in the European Journal of Cardiothoracic Surgery in 2014. And what they found was that those individuals with an isolated root phenotype tend to have fusion of the right and left coronary cusp. However, if you have the ascending, there was no correlation found with the ascending phenotype. So an individual is just as likely to have a right-left coronary cusp as a right non-coronary cusp fusion. And this result was reproduced by Evangelista earlier this year. They too found that those who have an isolated root phenotype tend to have fusion of the right and left coronary cusp. There was no significant correlation with those with an ascending phenotype. However, those with an arch phenotype tended to have, they would more likely have fusion of the right and non-coronary cusp. So does this matter at all, and who cares? You know, I think that at this point, I'm not sure this information is all that useful from a clinical standpoint. At this point, I'm not really sure if we know that those with a fusion of the right and left coronary cusps are going to be more likely to dissect than with other valve types. And I also don't think that we can say confidently that those with a root phenotype who are dilated are more likely to dissect than those with an ascending or arch phenotype who are dilated. I don't think the data is robust enough. So at this point, there's so much heterogeneity associated with BAV. It's been very difficult to characterize the valve type confidently, and I don't think morphology can reliably predict pathology. So a lot of investigators now are also interested, and this has been going on for years, is trying to figure out what the etiology of this BAV aortopathy is. Is it nature or is it nurture? Or more specifically, is it genetics versus hemodynamics? And if we can better understand the relative contribution for a specific individual, then perhaps we would be able to give more specific and tailored treatment recommendations. So there's a lot of data out there to support this genetic hypothesis. First of all, we know that bicuspid aortic valve is heritable. And this was a study published in 2004 in JACC. And they looked at 54 probands with a bicuspid aortic valve. And as you can see from their pedigrees, they're highly enriched with BAV. So the study suggests that if you have a first-degree relative with a bicuspid aortic valve, then your likelihood of having BAV is 9%. And if you have multiple members with a bicuspid aortic valve, then that probability of having BAV rises to nearly 25%. Bicuspid aortic valve oftentimes occurs sporadically, but if it's inherited, it's thought to be inherited in a autosomal dominant inheritance pattern with incomplete penetrance and variable expressivity. Another argument, or an argument that supports the idea that this is more genetic related, is that if you look at those individuals, or look at the first degree relatives of those individuals with a bicuspid aortic valve, even though they have a tricuspid aortic valve, they still tend to have larger aortas than the control population. So this was a study published in 2009 by Biner and colleagues, and this is what they found. They found that those with BAV, about over 50% had aortic dilation, but what was interesting was that those first degree relatives, even though they had a normal functioning tricuspid valve, 32% had aortic dilation. And this was significantly higher than what you would expect in the general population. The other argument that supports the idea of genetics is if you look at children. So children with bicuspid aortic valve almost invariably will have higher or larger aortas than those compared to their tricuspid aortic valve counterpart. And you can see here that the curves diverge early on. And so it's hard to argue that it's due to hemodynamics if we see that those, even in children early on, have larger aortas despite normal hemodynamics. One of the first histopathologic studies that was published on BAV was done by Victor Bicuspid in the Lancet in 1972. And Victor Bicuspid is often known as the father of genetics. And he was studying a family, basically a father and a son. Both had a bicuspid aortic valve, and unfortunately both dissected. And he took their aortic tissue samples and he looked at it, and he noted that they had cystic medial necrosis. As you can see here, there's increased fragmentation of the elastic layer, and this is there's pulling of the extracellular matrix, which is rich in mucopolysaccharides. And he writes, it was suggested that valve disease places unusual hemodynamic stress on the aorta, leading to structural fatigue. It was further thought that congenital weakness in the aorta is unlikely. Now I'm not so certain. So he was also looking at individuals with Marfan syndrome, and he saw the same kind of tissue pathology in those with Marfan syndrome. And what he thought was that there must be this inherent fragility associated with the aorta. So we know that the strength of the aorta lies in the interaction between elastin and collagen with smooth muscle cells, and this is anchored by fibrillin 1. And what we also know is that individuals with a BAV aortopathy have relative deficiency of fibrillin 1, and this results in disruption of this architecture and degradation and apoptosis of the smooth muscle cells, which causes release of matrix metalloproteinases, which causes further degradation of this architecture. And if you look at some of the tissue samples of those with a bicuspid aortic valve versus those with a tricuspid aortic valve, and you look at their aortas, you can see there's relative deficiency in fibrillin 1, and there's increased expression in matrix metalloproteinase 2. And this is also something that has been described in Marfan syndrome. Finally, further kind of supporting this genetic hypothesis is if you look at the genes that are associated with BAV. There's not been a lot of genes reliably associated with BAV, but the ones that we think are related, we see a higher prevalence of BAV. All of these genes are also associated with aortic aneurysm and early dissection. We have TGFBR1, TGFBR2. There's been reported to have, the studies suggest there's an increased prevalence of BAV in these populations. This is the gene that causes Loeys Dietz. FBN1 causes Marfan's. ACTA2, which is also a gene we know causes early aneurysms and dissections, have also been more highly associated with bicuspid aortic valves. One of the only genes that have actually been reliably associated with bicuspid aortic valve and aortic aneurysms is Notch1. And I think it's interesting in that Notch1 is involved in cardiac neural crest cell signaling. And as you can see from early embryology, these neural crest cells are involved in formation of the aortic valve, which we see here in blue, as well as the ascending aorta. So it makes sense that there's this both genetic and embryologic link associated with the bicuspid aortic valve and the aorta. So what about hemodynamics? It seems like every couple years the pendulum continues to shift back and forth. And I think more recently there has been more enthusiasm about this hemodynamic hypothesis. And I think this largely has to do with some 4D MRI flow studies that shows that there's differential flow patterns between those with a bicuspid versus a tricuspid aortic valve individual. So this is a 4D MRI, and as you can see here, there's a normal flow pattern. My arrow is not pointing, but there's a normal flow pattern seen in the picture on the left. That's a normal tricuspid valve. I'll play it again, hopefully. And this other picture here is one with a bicuspid aortic valve, and you can see that there's this helical flow pattern with increased turbulence. I think it's a pretty striking finding. You don't have to be an MRI expert to see that. And so people started looking at this and started looking at the differential flow patterns in those with bicuspid valves as well as those with a tricuspid valve. And this was a study published in 2013 by Bissell. And what they did, these investigators just took a group of individuals with BAV and monitored their flow pattern. And what they found was basically 4 different flow patterns. So a group of individuals with BAV had a normal laminar flow pattern. There was another group, the most prominent pattern actually was found was this right-handed helical flow pattern, where these individuals had the flow through the aorta was initially directed anteriorly and to the right. And then there was another subset that had a left-handed helical flow pattern where flow was directed posteriorly and to the left. And then finally, there was a group that had kind of complex flow pattern that wasn't easily characterizable. I think the bottom line of this study, though, is that those individuals with a normal flow pattern tended to have normal-sized aortas. They were very similar to the size you would expect, or there was a very similar to the size they found in healthy volunteers. But those with an abnormal flow pattern, regardless of the type, tended to have significantly larger aortas. Subsequently, or kind of during that same time, Barker and colleagues found that specific flow patterns were actually associated with BAV morphology. So those individuals with a fusion of the right and left coronary cusp tended to have this right-handed helical flow pattern, and those with a fusion of the right and non-coronary cusp tend to have this left-handed helical flow pattern. And why was this interesting? Well, using 4D MRI, they were able to, and I'm not really sure, there's a lot of complex physics involved, but they were able to figure out the wall shear stress in the aorta. And what they found was those individuals with a right-left coronary cusp fusion with this right-handed helical flow pattern tended to have increased wall shear stress at the aortic root, at the sinotubular junction, compared to those with a right non-coronary cusp fusion. However, if you look at the ascending aorta in these individuals, even though their wall shear stress tends to be higher than those of the control population, they were fairly equivalent in those with a right-left or a right non-coronary cusp. And so this seemed to make sense when we look at the associated aortopathies. We know that individuals with a right-left coronary cusp fusion tend to have aortic root dilation or an ascending phenotype, where those with a right non-coronary cusp fusion tend to have dilation at the ascending aorta or in the arch. So people have argued that this hemodynamic findings actually explain the aortopathy. So Guzzardi and colleagues took this one step further, and what they did was they took individuals who were going to get an aortic repair or an aortic surgery, and they looked at the wall shear stress and took tissue samples in areas where there was normal wall shear stress, in areas where there were elevated wall shear stress. And what they found was that regions of high wall shear stress had fewer elastin fibers. You can kind of see this here. They were further apart than those in the areas with normal wall shear stress. And what they also found at a molecular level is that there was increased expression of MMPs as well as TGF-beta in the areas with elevated wall shear stress compared to normal wall shear stress. So again, it seemed like hemodynamics actually could also not only explain the aortopathy phenotypes, but it also could explain the differential molecular findings that we find in BAV. So what happens to the aorta after the valve is replaced? If it was all secondary to hemodynamics, we would think that the aortic pathology would stabilize and perhaps the rate of growth of the aorta would be similar to that of the normal population. And the first couple studies actually didn't find that to be true. But more recently, there's been 5 different studies published, and it actually seems to support this hemodynamic hypothesis. I'm just going to show the most recent study published in 2016. And what they did was took patients that were getting aortic valve replacement and looked at rate of growth, and this was about a 5-year period. This is the top slide. And you can see in red the rate of growth for those with the bicuspid aortic valve. The slope is significantly higher than those with the tricuspid aortic valve that were getting valve surgery. They then looked at these same patients and looked at them after valve surgery and followed them for about a period of 4 years. And you can see that the rate of growth seems to stabilize and be comparable to that of those with a tricuspid aortic valve. Now, this is different from one of the earlier studies in 2003 where it suggested individuals with BAV continue to grow despite AVR. So I think the data is a little bit mixed. But more recently, it seems to suggest seems to support the hemodynamic theory. How about the rate of dissections after AVR? So again, a lot of different studies with somewhat varied results. If you look at the very top study by Russo, it suggests that even after you get a valve replaced, you still have a pretty high rate of dissection. This study showed a rate of 10%, but all the other studies that looked at this have actually shown quite a low dissection rate after an AVR. And interestingly, there was a study published about 2 years ago where it actually suggested it really depends on the valve type. So if an individual with BAV got a replacement due to aortic regurgitation, then their risk of continual dissection after AVR was found to be 10 times higher than those that got an AVR for aortic stenosis. And this suggests that perhaps these two entities are not the same, and that those with AVR and those with a BAV with aortic regurgitation should be treated differently than those with aortic stenosis. So we know that there's this interplay between genetics and hemodynamics, but unfortunately, I don't think we really still understand what the relative contribution is for a particular individual. And this has not allowed us to give more specific guidelines. So I'd like to now kind of segue to the guidelines. And as you can see, over the last 15 years, the recommendations for aortic surgery in those with an isolated BAV aneurysm has been quite variable. It actually nadir down to 4 centimeters in 2010, and now over the more recent years, we've become more conservative with our threshold recommendations. In 2014, ACCHA guidelines actually moved the threshold for surgery from what it had been 5.0 centimeters for an elective aortic aneurysm to 5.5 centimeters. The question is, why did they do this? And I think partly it was because these contemporary studies show that the incidence rates for aortic dissection is actually quite low. I mentioned this Olmsted County study. A similar study looking at the Toronto registry also showed that the dissection rate was quite low. Out of 600 plus patients, there was only 5 dissections. I think another factor that played a role in this change in recommendations is that there's been a couple studies now that have looked at the characteristics of those with a BAV versus a tricuspid aortic valve and dissections. And what they found was that individuals with a bicuspid aortic valve tend to dissect at larger aortic sizes than those with a tricuspid aortic valve. I think this is a surprising result, but it's been reproduced a couple times now. And in this study, the size at the time of dissection for those with BAV was 6.6 centimeters, and in the tricuspid aortic valve, it was 5.6 centimeters. So this would suggest that we don't need to be more aggressive with our threshold recommendations. So not everyone was very happy with this kind of change in guidelines, and particularly a group of surgeons in the Cleveland Clinic thought that this was not the right thing to do, and they decided to look at their own study. And so they published this shortly after the guideline changes. And what they did was they took their BAV population and kind of isolated those patients with a large aorta. So they, all the patients or individuals in this study had an aorta of 4.7 centimeters or bigger. And they looked at their complication rates, and I think the most interesting thing was that they had 10 acute aortic dissections, and the average pre-dissection diameter was 5 centimeters. And this suggested that perhaps we should be more aggressive with our threshold recommendations. What they also did was they used this information to model the risk of aortic dissection, or the probability of dissection, based on aortic dimensions at the sinus of Valsalva and at the ascending aorta. And they found that the risk of dissection remained pretty stable as long as your sinus of Valsalva was 5 centimeters or less. But once it reached 5 centimeters, there was this slow increase in the risk of dissection. What they also found in the ascending aorta, that there was this inflection point where the risk of, or the probability of dissection seems to exponentially increase. And this inflection point was found to be at 5.3 centimeters. What they also, I think, and also an interesting point here is they also looked at cross-sectional area to height ratio. And what they found was that this was actually a better predictor of dissection than absolute diameter. So I think that's something that we might want to keep in mind when we're looking at these patients. So the real question is, what is the risk of surgery versus the risk of dissection? And we know that surgery is not necessarily a benign thing. This is Bill Paxton. I don't know if you guys are familiar. He was in a bunch of movies. He actually had a bicuspid aortic valve and aortic aneurysm and was getting an elective repair and ended up dying from a stroke earlier this year. So contemporary studies suggest that the risk of mortality from an elective aortic replacement is 3.5%. And certainly this is not something to just ignore. If you're getting surgery for an emergent reason, the risk of mortality rises to about 22%. And so if it really is 3.5% as our risk of mortality, then it probably makes sense to make our thresholds a little bit more conservative. However, there's been a lot of other studies that have suggested that this mortality risk is inflated, and those from Cleveland Clinic suggest that their Mortality risk for elective aortic surgery is only 0.25%, and the risk of stroke is only 0.75%. So with this information, it seems like, or there was a 2016 guideline clarification. And the kind of the gist of this is that the writers, and unfortunately Otto's not here, but the gist of it is basically we don't know what the right threshold is, and they admit this in their guidelines. And they said, well, it seems like 5.5 is reasonable. That's actually the recommendation we use for the normal population. But they also put in as a class 2A recommendation that it's reasonable to do surgery in those with an isolated aneurysm and a BAV who have an aortic dimension of 5 centimeters or higher, but are a low surgical risk candidates, and they're being done by a surgeon that has good results. So I'm assuming that perhaps in our population here at the University of Washington, maybe we should be referring these patients at a dimension of 5. So the real, I think, problem is that, or the real issue here is we need better risk prediction models. And we know that size matters, but it's probably not everything. There's a lot of different factors such as genetics. Maybe we should be looking at wall shear stress, body habits and size. Perhaps we should be treating those with AI much differently with those with AS. So I think we have to use all of these things and factor it in our decision making. So what's the big fuss? That's kind of how I kind of titled this talk. And I think that if you look at it from kind of one standpoint, the risk of aortic dissection is quite low, and people do really well. Arnold Schwarzenegger actually had a bicuspid aortic valve. He had a Ross procedure. I'm sure he didn't follow any of the exercise recommendations that was given to him by his doctors, and he did pretty well. So perhaps this is all overhyped. On the other hand, I think at least within the field, there's this large controversy because there are so many patients with BAV. So in the United States alone, every 7 minutes, someone is born with a bicuspid aortic valve. There's probably about 5 million people in the US with a bicuspid aortic valve, and over 50% have aneurysms, and some of them will dissect. And it's preventable. But unfortunately, there is a lot of uncertainty. So I think that's where all the fuss lies. In conclusion, I like to end with this quote by William Osler. There's no disease more conducive to clinical humility than aneurysm of the aorta. So I'm happy to take questions. Dr. Levy.
In somebody without a family history, do you screen for bicuspid aortic?
Yeah, so without a family history of, so someone with a BAV and, yeah, but there's an individual.
Everybody in the room here, should we all have an echo to screen for bicuspid aortic valve?
I don't think so. No, because usually people with, if you're having a good exam, if you listen to someone actually and use your stethoscope, you will probably detect a valve abnormality, and you should be able to detect that, and people will tend to declare themselves before their aorta gets that large. If they have AI, they'll develop AI early, and so you should be able to detect that by physical exam. So the other question I think is, should we be screening all those individuals who have a bicuspid aortic? Should we be screening their first-degree relatives? And I think that's been recommended in the past in the guidelines, but it's probably not all that cost-effective, to be honest. And we should be able to detect them by our physical. If you talk to Dr. Otto, she had told me that everyone should get an echo at age 50 anyway. It should just be part of like a random colonoscopy. So you could say that maybe all of us should be getting an echo at some point in our lives.
Don't order them all at once, please.
David.
Excellent overview. One of the questions was that in some older data from the IRAD registry, they suggested that not only was the rate of dissection very low by bicuspid aortic valve, but the mortality of dissection was much lower than the general population of dissection. So has that been followed up, or? So that obviously influences your decision about do you operate prophylactically or not.
Yeah.
If you have a dissection, but it can be managed without major morbidity or mortality, that would be different.
I think that the individuals who dissect with BAV, at least if you, in general, they tend to be younger and they're probably I mean, the people that dissect as they get older are people with a lot of comorbidities with atherosclerosis, CAD, and there's probably a lot of, it's not looking at the same population. So I'm not surprised that those individuals with bicuspid aortic valve and that dissect do better. I'm not aware of other studies that have continued to follow that to see if that's the case. But it seems logical to me that those individuals probably do better in surgery because they're probably just a little bit healthier to begin with. Eric.
Can you talk a little bit about your views on the role of medical therapy and activity restriction in patients with bicuspid valve aneurysm? Yeah.
So I actually have a slide on this. I was going to present it, but let's see if I can find it. So the ACC/AHA guidelines are really restrictive. And I think it's overly restricted, to be honest. They say that no competitive sports at a dimension of 40 or higher in men and 3.6 in women. And I think that's a bit ridiculous, in my opinion. There's no data to support this. The European guidelines are a little bit more lax. I think once you reach an aortic dimension of 4.5, that's when I would start using some of the same recommendations that I do with Marfan syndrome, where I say, you can exercise, but be able to speak. If you're going to lift weights, be able to do 20 reps without problems. That's kind of that's kind of what I recommend. But I don't think, I did some research on this, and there is no good data to actually support what we're saying, and I think it's all anecdotal.
Medical therapy?
Oh, medical therapy. I don't, maybe beta blockers, but the study that they looked at this in Marfan syndrome was pretty poor. And certainly losartan didn't show that it was any better than beta blockers, and that's for a different pathology. I don't think BAV has the same pathology as, say, Marfan's or Loeys-Dietz. So if they're hypertensive, I'll treat them. Dr. Dietz.
Yeah, real nice talk. A couple of questions. One is, what about screening? Once people have a known bicuspid aortic valve, I'm sure many of us have patients in our clinic.
Yeah.
We get them every year, and it's like the same. And, at what point do you taper the frequency of surveillance?
So I think you have to survey them for their valve issues, and because you're surveying them for their valve issues, you're going to also be looking at their aorta.
What if they don't have valve issues?
Yeah. So that's, I think, rare, but if they don't have valve issues, I usually start out with a CTA or an MRA just to make sure their aorta looks pretty good. And I probably wouldn't get it, if it's completely normal, I might get one in 5 years. And if that's completely normal, I may not keep following them. I don't think there is a standard. Certainly if they're dilated, we should be following them regularly. But there is a group of patients that don't dilate. And I actually think people with AS tend to have more of this hemodynamics, whereas AI may be a little bit more genetic. I think there's some data to support that. So maybe with AI, you would follow these patients more, but you're going to follow them anyway for their valve. So, and I think it's rare, but not, it does happen occasionally where they just have isolated regurgitation with no valve problems. But you're probably going to check out their valve a little bit later anyway, because these patients tend to be young. And if they're older and have normal dimensions, I'm less concerned.
And the second question is, so maybe you went over this, but there was a lot of information there, and I'm not sure I caught it. But in programs where people have regular surveillance, what is the incidence of unexpected dissection? Where people are followed.
It's very, very low.
Yeah.
I think the study from Mayo Clinic was kind of what that was. They followed these patients really carefully, and the dissection rate was 2 out of 416.
Yeah.
And I think actually the 2 that I dissected kind of glossed. They kind of weren't as carefully followed, but they dissected with an aortic dimension of 5.
Yeah.
So, you know, there is definitely this subset of people that probably are at higher risk. We just don't know, we haven't identified that population.
So it's unlikely that some highfalutin multifactorial score is going to do better than that, right?
You mean like if we looked at their washer stress and said, hey, your washer stress, I mean, it might. I think
that's a high bar, 2 out of 400.
yeah, it's pretty high. I agree. So, in my opinion, it's a little bit overhyped. There is a lot of controversy over this, but within the population. And I just recently wrote a chapter with Alan Braverman, who's really big in this field, and he's like, "Oh, this is way too low. We should be doing surgery on people at 5." But I'm not sure I agree with that because I do think that in general people don't dissect. But I haven't seen one yet. So as soon as I see one that dissects, I'll probably have a different tune. Dr. Kirkpatrick.
Having a personal interest in this topic and through some of what you were talking about, I wanted to go back to Eric's point in your elegant presentation of the pathophysiology and the mention of metalloproteinases. And unless I'm mistaken, statins actually inhibit the actions of matrix metalloproteinases. Is there any reason why one might want to go on a statin in order to attempt to stabilize the aortic pathology?
I'm not sure, again, I'm not sure if this is there's much data to support that. I don't know, maybe Dr. Dichek knows more than I do statins affect.
I'm not familiar with those.
But I'm sure maybe there's a study that shows that. I think everyone should be on statins, to be honest. If you look at Dr. Relwan's talk, so yeah, put him on statins.
So Andrew, that was a really terrific talk. It does make sense to me that the aortic valve morphology and the resulting flow patterns would help to define where the type of dilatation would occur in a genetically abnormal aorta.
So I think there has to be, well, I don't know, because there's plenty of people with aortic stenosis that don't dilate. Or maybe they're marginally dilated, and maybe that's due to flow. But when you see these individuals have 5.6, 5.7, then there's probably a larger genetic component.
Yeah, so then I think it's the second part. The valve morphology does not seem to predict the underlying genetic abnormality. We're looking at it the other way. I think that Loeys paper about TGF-beta receptor and bicuspid valves, gosh, that's about 12 or 14 years old now. But they had some nice pedigrees in that to show that people that had the same genetic abnormality could have a variety of different phenotypic manifestations, very different.
So people think there's 2 genes involved, there's 3 genes, multiple genes. And even if you look at the Notch1 population, they have different valve morphologies. So it's not something, I mean, we've been working on this for years, right? And it's very common, but no one's been able to come up with an answer. So I think it's very complex, and there's probably a lot of heterogeneity. So it's not just one disease. It's probably like heart failure. There's a lot of different etiologies, and we're just trying to lump it all into one, but that's probably not the way to look at it.
There's also potentially a challenge is if you identify with somebody with a bicuspid aortic valve, that doesn't necessarily mean that if a family member who doesn't have a bicuspid aortic valve doesn't have this genetic word of caution there. Okay, great. Well, thank you very much.